we're going to go ahead and start our session. So this session has been changed to a hybrid format. A number of our speakers are online. There were visa problems, and I think airline tickets have become expensive because of all the Trump tariffs. But for whatever reason, a number of our speakers will be here online. So we're modifying our format very slightly. I'd like to begin by introducing our first pre-recorded online speaker. This will be Dr. Andreas Müller from the World Health Organization, but I'd like to also introduce myself, Nathan Congdon, representing Orbis, and Queen's University Belfast and Zhongshan Ophthalmic Center, and my co-panelist who needs no introduction. If you'd like to introduce yourself.
I'm Tulsi Raj Ravilla from representing the Aravind Eye Care System.
Fantastic. So today our format will be 3 speakers, 2 of whom will be doing pre-recorded online speakers, and the third will be Mr. Tulsi. And then we will have 2 separate panels, and the panelists, some will be online and some will be present here, so a hybrid session. Our first online speaker then will be Andreas Müller from the World Health Organization. This should be pre-recorded.
Hello, my name is Andreas Müller. I work with the Vision and Eye Care program at WHO HQ, and I'd like to give a
He's not audible. The audio.
relatively new but certainly major WHO initiative named SPECS 2030. The history of the initiative goes back to a World Health Assembly resolution from 2021, in which member states endorsed 2 global indicators and related targets for the year 2030. Those are a target of a 30 percentage point increase in effective coverage of cataract surgery and a 40 percentage point increase of effective coverage of refractive error by the year 2030. And importantly here to recognize the term effective, which refers to a good visual acuity outcome post-surgery or post-refractive error correction. And of course in WHO we define good outcome with visual acuity as 612 or better. So what we're aiming for here is a coverage of services leading to 612 or better visual acuity. So if we set ourselves a global target, of course it is important to understand our baseline. And here we estimate that in the year 2020, only 36% of the global population requiring refractive error services have received a service with an effective outcome, i.e. 612 or better. So this translates to just over about 1 billion people globally that do not have appropriate correction for refractive error services. And if we're talking about a 40 percentage point increase at global level, we are really talking about achieving 76% of global coverage of effective refractive error coverage. So looking at these staggering figures, I'm sure you agree with me that now is the time for action. The time for action to prioritize refractive error services as a health issue, as a health concern, and as a responsibility of health systems to deliver a good quality service to each person that requires these types of services and refractive error correction. The SPECS 2030 initiative was launched pretty much 1 year ago at WHO headquarters, and the sole mission of the initiative is to support countries towards their efforts in achieving the World Health Assembly endorsed 2030 target on refractive error coverage. SPECS is also an acronym for the 5 key strategies that the global initiative is working towards. And here the S in SPECS stands for the need to improve access to refractive services. The P stands for the need to build the capacity of personnel to provide services. The E stands for the need to improve population awareness and education. The C stands for the need to reduce out-of-pocket cost of services, and the second S for the need to strengthen surveillance and research around refractive error data, and especially with a focus on younger populations. For each of those 5 strategic areas, we have defined what we call desirable outcomes, or outcomes that the initiative is working towards achieving. The overall goal is, however, to create sustainable increase in refractive error coverage by integrating these types of services within health systems in a sustainable way, and to provide services that are accessible and affordable and available to all people that need them. So how are we actually going to achieve these various strategic or desired outcomes? So here you see 3 tiles that outline the key, what we call areas of engagement of SPECS 2030. The first one focusing on really a sector that is currently providing the majority of these types of services around the world, and that is the private sector. So we've started engaging with key companies, service providers from the private sector on their contributions towards the objectives of SPECS, especially at country level. The second type of work that we focus on is the sort of what we call normative work of WHO. So this is what we are contributing in terms of our technical support to countries. That may be the development of guidance, materials, of any technical products to support the planning and the implementation of activities at country level. And of course, there are already a number of players, whether that is international NGOs, professional associations that support countries around refractive error services. So here we have established a global SPECS network of these existing key players to come together and speak with one voice to governments advocating for SPECS and working towards the global target. Here you see a photo of the formal launch of the global SPECS network in Geneva in 2024. Here you see a list of the current 43 members of the SPECS global network. And here you see a list of example normative works or technical products WHO has developed in the past couple of years to support not only refractive error but eye care services planning and implementation, and also monitoring. So we have various products to support workforce planning, to help develop education and prevention campaigns, but also to develop surveillance programs and monitoring frameworks around eye care and refractive error. I'm really glad to see or to say that so far we've had fantastic uptake and buy-in from a number of countries around the world. Here you see photographs on the very left from India, where we launched a SPECS Assam model, which is Assam, a state in the northeast of the country, formally launched SPECS Assam in November last year. In the center you see a photo of the national SPECS launch in Thailand, and on the very right you see a launch of the Malaysian version of SPECS named MySPECS here, also launched in November last year. Here you see a list of additional countries whom WHO is working already, from which we received a formal request from governments to support the implementation of SPECS national level activities. And in bold you see also, I'm glad to say, a list of countries from the Southeast Asian or Western Pacific region of WHO that are about to launch national initiatives. With the limited resources available, it is important to also be smart in terms of selecting key geographic areas. And here you see a map of the world outlining estimates for effective refractive error coverage rates, showing that the African region or the Southeast Asian region certainly would need to be key priority areas, geographic areas for SPECS, at least at the initial phase of this initiative. And these are areas that we're certainly prioritizing when it comes to the supporting from our side. So what are the sort of usual first steps or the next steps in terms of taking specs further at country level? So in our experience, once a country is requesting WHO involvement and agreeing to a specs 2030 uptake, first step might be to conduct a national situation analysis. An analysis of the refractive area systems to help identify priority areas of work, what is working well, what needs to be improvement, and then defining specific activities that are then integrated within the relevant health plans, whether that would be a national eye care plan or a national NCD plan, etc. So if you are from a country and you did not see that your country is part of that list that I showed in the previous slides, perhaps you may want to advocate this initiative to your government, to the key stakeholders in your countries, and please feel free to contact WHO for any technical support or further discussion on how to implement specs 2030 in your country. Thank you very much for your attention, and I wish you a successful meeting.
Terrific. So thanks very much for that terrific speech introducing specs.
Cutting-edge research, global collaboration, DLC remains at the forefront of ophthalmology in China. On the occasion of our 16th anniversaries, we are excited to host the International Ophthalmology Hospitals Presidents Summit. We welcome you to unite in Guangzhou for this precious ophthalmic assembly and immerse yourself in the charm of South China. In terms of research, DLC houses China's only state key laboratory of ophthalmology, focusing on cutting-edge research in stem cells, neurobiology, and artificial intelligence. We have been ranked #1 by the Science and Technology Evaluation Matrix for 10 years in a row. Our pioneering work has positioned us on the top list of Nature Index for Eye Institute's research output. DLC serves as a national education base for PhD students and clinical residencies in ophthalmology. Our graduate students and alumni have achieved national recognition, with many becoming professors at renowned international universities. A study published in Nature has revealed the alarming surge in myopia among Chinese students. The myopia prevalence among children aged 15 has reached the unprecedented level of 78%. This myopia boom among children has drawn widespread attention from scholars both in China and abroad. However, myopia research faces multiple challenges. For example, myopia screening is limited to a concentrated sample population and a singular screening method. Conducting myopia research is resource-intensive due to its complex heterogeneity and challenging in individualized prediction of myopic risk. To address these issues, artificial intelligence offers a novel approach by simulating the neural networks of human brain, enabling rapid learning and uncovering potential patterns in data. AI provides cost-effective solutions with fast diagnostic speeds and has been extensively applied in various medical fields, including ophthalmology. Recently, there has been a growing interest in medical big data due to its ability to predict future outcomes, offering distinct advantages including unified resources, reliable data, large-scale analysis, and self-identification of patterns. Consequently, it is highly suitable for conducting myopia research. Today, I will introduce several studies we published previously related to myopia and big data analysis. As we all know, China has experienced major increases in myopia prevalence, influenced mainly by environmental factors. Indirect evidence suggests a potential association between green space and myopia, as urban children with limited access to green spaces exhibit higher prevalence of high myopia due to the challenges in quantitatively assessing green spaces. Few reports have evaluated such relationships. Satellite technology has offered new insights into epidemiology and its application to human health. It can be used to monitor and measure the green space environment. The normalized difference vegetation index, NDVI, is used as the measure of overall green space exposures, where ranges between -1 and 1, with higher numbers of number indicating more greenness. Therefore, we use satellite technology to assess the green space exposure in primary schools and analyze its relationship with risk of school myopia. We conducted this study in Shenzhen, the largest immigrant city in China, which is undergoing rapid urbanization. A total of 113 schools in Shenzhen participate in this study. We included school children from grade 1, about 6 years of age, and to grade 4, 9 years of age, representing a period of rapid refractive error changes. Eye refraction data were collected annually from 2016 through 2019. We generate NVIDIA maps from the original high-resolution Gaofeng 2 satellite images to assess green spaces within the boundaries of the schools. To evaluate the potential impact of seasonality, the time integrate of monthly NVIDIA values in our study period were calculated. We also calculated the green space morphology of the campus and the surrounding buffer zones. 0.25 was the threshold value of NVIDIA used for green space patches extractions. 8 landscape metrics were then obtained to measure area, aggregation, and shape of the green spaces. 0.1 unit increase in the NVIDIA were associated with a 3.6% low increase in the myopia prevalence at school level and 27.9% reduction in the myopia risk at the student level. Further analysis of morphology metrics of green spaces revealed that increased proportion, aggregation, and cohesion of green space was correlated with slower progression of myopia. In addition to investigating potential of green space for population-based myopia prevention, we have also focused on population-wide myopia screening models using artificial intelligence technology. Slow analysis using convolutional neural networks, CNN, we can discover subtle facial features that clinical doctors find hard to identify, thereby achieving recognition of genetic disease. Therefore, this study aims to utilize the fine-grained recognition capability of CNN for screening myopia children. We collected 2,350 ocular appearance images from 1,175 children in a standardized scene. Other information, including refractive and demographic data, were also collected. We resized the ocular appearance image to 224 plus 224 pixels and extracted facial features using a widely employed CNN VGG face with transfer-link learning. The algorithm can distinguish between myopia and non-myopia using a VGG phase network. In the validation test, our DLS achieved an AUC of 0.927, a sensitivity of 81.13%, and a specificity of 86.42%. The risk of children developing high myopia has become a great concern and burden for the healthcare system. Therefore, identifying those at the greatest risk who should undergo target therapy is of great clinical importance. In the next study, we have developed a prediction algorithm based on machine learning techniques to uncover the key determinants of high myopia and accurately predict its development in adulthood at an early stage. We extracted data from more than 500,000 electronic medical records collected between 2005 and 2015. We employed the random forest machine learning approach to develop a predictive algorithm, utilizing age examination, SE, and annual progression rate as input variables. The algorithm was used to predict SE and whether patients will progress to high myopia in the subsequent 10 years. Our algorithm provides high precision predictions of high myopia as early as 8 years in advance. This study for the first time used large-scale data collected from electronic health records to demonstrate the contribution of big data and machine learning approaches to improve prediction of myopia progress in Chinese children. The system has been deployed on cloud platform at Zhongshan Ophthalmic Center. Based on medical big data and interdisciplinary technology, we conducted a comprehensive analysis of macro-level greenery indicators of affecting myopia, implemented intelligent screening with facial features, and produced an intelligent prediction model for high myopia over 10 years. Our findings provide novel insights for prevention and management of myopia at both population and individual levels. Thank you for all your attention.
So that's terrific. That's great. So Director Lin has given us a peek at some of the novel tools that are going to help us to achieve the goals that have been laid out by SPEC over the next decades. We're now returning to speakers who are present, able to attend today, and our next speaker will be my co-chair, Mr. Tulsiraj Ravila from the Aravind Eye Care System. And he'll be speaking to us today on enhancing refraction services, design and delivery perspectives.
Thank you. I'll be spending the next few minutes more focusing on how we achieve the goals of effective refractive error coverage. Just to recap, till a few years ago, maybe I don't remember the exact date, probably till a decade ago, all the assessment of visual impairment or blindness was based on best corrected visual acuity, which literally buried the recognition of refractive error as a cause. And I think that got rectified. And we have these huge numbers now of almost a billion people who have unaddressed refractive error correction. And then this is what prompted the goal that Andreas so described in detail about addressing the refractive error as a major challenge in eye care. And that gave birth to this global initiative called as SPECS, And then as he outlined, there's a lot of effort that's going into creating that ecosystem which will promote better services for refractive error correction globally in a very, very comprehensive way, looking at service delivery, the resources like people, awareness creation, making it affordable, and monitoring. So as he mentioned, for the very first time, WHO has defined a threshold as to when we intervene for refractive error correction. And that's very, very important because it helps us define the denominator, and as well as they also define, put a threshold for outcome of 612 or better, now which helps us to determine or compute the effectiveness. As he showed in one of his slides, the overall coverage is around 43% globally, while the effective coverage, which means of those having the refractive correction, mostly glasses, some could be contacts and surgery, about 36% had a vision of 612 or better, what is called as the effective coverage. And the goal, as he mentioned, was to increase it by 40%. That means this 36% should become 76%. So that is the goal. And my talk is more about from a very practical perspective as to how we can achieve this. So one proposal I'm making is that recognizing that refractive error, with the exception of myopia that we talked about, is a condition that is neither preventable nor self-healing. So we have to intervene, which means it is in the hands of the providers to make a difference. So that's the first argument that I'm making. And the broad actions are about, one is enhancing access. That is, you get more people into the system, those who are not accessing care. And the other one is when they access the care, we make sure that everyone gets refracted, given the right prescription, and then they're enabled to get the glasses. Okay, and when we do this, we would achieve the target. And I want to give two examples of how this is possible. One is, I want to share with you some data that we did from a community survey recently. In the survey, we found that of the people who had refractive errors in a population-based survey, I'm not going into all the details, about 2,000 odd people had refractive errors, of which 680 were wearing glasses, which gave them the vision of 612 or better. Now, what we call as met need was 33%, and 65% of them were not wearing glasses. A small proportion were wearing glasses, which were not of the correct power. So if we are able to correct those wearing the wrong glasses, maybe even half of them, there'll be a marginal increase in the effectiveness. Will go from 33% to 34%. In the same survey, we also looked at the people who are not wearing glasses, 1,314. Of them, close to 300 people, 289, had actually gone to an eye care provider in the last 12 months. But for some reason, they were not refracted and given glasses. Okay, again, a provider's problem, which means that that entire group, if we were alert, we could have given glasses. And had we done that, then the coverage goes up from 34% to 49%. And then of the remaining, that is 1,314 minus 289, even if you cover just 50% of them, which will take some effort, but very doable, then the coverage goes up to 74%. More or less that 40% increase that is required. So we can very clearly see that achieving this is very much possible, even with the current system, only if you become more sensitive about these opportunities. And I also want to share similarly data from the hospital setting. So what we did was we took 1 day's outpatients from our hospital. We have a network of several hospitals and mission centers. And that particular day, we had examined 15,000 odd outpatients, of which a total of 3,200 plus had refractive errors, and of them 1,590 were wearing the correct glasses. And then few of them were wearing inappropriate glasses. So the total coverage was 54%, with about 49% would be called as effective coverage. And then of those who needed intervention, that means their vision would have improved to 612 or better. For some reason, I don't know why, but we only prescribed glasses to only 35% of them, which means there's been a gap in our service delivery of about 65% not diagnosed or prescribed glasses. Of those who were prescribed glasses, 70% bought them, 30% did not. So there is a compliance gap of 30%. Again, addressable. So when we compute all of this at the end of the visit, that 48 or 49% became 61%. So there has been some improvement, but then this has been done without any special sensitivity or attention to addressing this problem. So I'm just showing a what-if condition. If we're able to close 50% of those gaps, that is, we are, instead of advising only 35%, let's say we advised 65, 70%. Or we are able to increase the compliance from 70% to 85%. Then the coverage goes up to 78%. So you can see that there's a lot that we can do as providers, and I believe that the entire effort or the ball is in our court. So some of the broad recommendations that we would like to make, or one, that we have a very clear protocol to make sure that everyone who will benefit from refractive correction actually gets the diagnosis under prescription. And today, in the era of digital medical records and all that, we can put alerts and checks and balances. And then having a checklist which will make sure that we're advising the right glasses to make sure that the quality is given. And we also have noticed that if you're able to give the glasses immediately, and if you had a good variety of choices, then the uptake increases quite a bit. I'll show you one particular example of that. And then to enhance the access, proactively doing screening in schools, workplaces, and we have got a lot of evidence. In fact, one of the landmark papers by Nathan did demonstrate that productivity jumps up phenomenally when you do workplace intervention, and then you recover the cost within a week's time or so. And of course, you need good documentation and continuous improvement. I'll conclude with this particular example. I don't know. Okay, I need to look here. So we did a study in outreach. When you do give only prescription, we found that only 25% of them ended up buying glasses or wearing glasses. But in the same outreach, like it's shown in the video, we're also able to dispense glasses on the spot. They choose the frame of their choice. You age and fit the glasses and give. The uptake goes up to 80%. It's the same kind of a population because it was a randomized controlled trial. But then the only difference was we're giving it right there, which means we completely eliminated the cost and effort of procurement. And that's a significant amount of money that is saved doing this. So I just want to once again conclude by saying that there is a lot that we can do without too much effort, I believe, to achieve the global target. Thank you.
Fantastic, Tulsi. Thanks very much for that. A lot of things to take away from that. I thought the idea that simply by making the glasses available at the time of outreach, you can get 80% of people to accept them. I think that's important. It is an important question as to whether they're going to continue to wear them. We know that's been a challenge. Unlike cataract surgery, in some ways, glasses are the easiest intervention we do, right? I mean, it's easy. You can hand out the glasses. They're inexpensive. But unfortunately, unlike cataract surgery, once they're done, every day the decision has to be made to comply with them, and that is a challenge. I'm interested to ask you a question. India's been phenomenally successful in managing cataract surgery. You have cataract surgical rates that are approaching or exceeding those of European countries, and refractive error seems still to be a challenge. Looking at the special case of glasses after cataract surgery, how is that working at Aravind? What proportion of people are taking glasses? Is it, and I imagine you give them free for the free patients. Do you have a sense of what proportion of patients are walking away with glasses after cataract surgery? And do you look at all to see if those are worn down the line?
Yeah. So it's a pretty high proportion, in the sense it's very much tied to having this follow-up mechanism. So the patients who come to the hospital get very detailed counseling about coming back. For those we go through the outreach, we go back to follow them up. So our overall follow-up rate is around 91%. And then integral to the follow-up is prescription giving glasses, where the patients seen in the outreach would get them for free under a scheme, and those who come to the hospital would buy whatever thing. And the uptake there again is very high. Prescription to uptake would be around 90-95%. And that's got to do with a lot with the counseling. Then they pay for it.
And that's the uptake of a prescription or the uptake of actual glasses?
Glasses.
The glasses.
Yeah, in fact, that 80% that we said was going back to the homes after 3 months to check who are wearing glasses.
Fantastic.
So I think there's got something to do about them paying for the glasses and continuing to use them. I think there is some correlation there. Yeah.
That ability to get glasses on and leverage India's huge success in delivering cataract surgery, glasses on after surgery, that seems like an important area to do and to make sure that every facility is doing as well as Aravind in that respect. Fantastic. That concludes the traditional sort of lecture part of our series. We're now going to have two panel discussions, both of them talking about EREC. Our first panel discussion is going to be chasing the EREC target, enhancing access. So the first one will talk about access, and the second one is going to talk more about driving demand. So for our first panel discussion, Tulsi and I will be joined by Professor Liang Lingyi from Zhongshan Ophthalmic Center, who will be assisting us in moderating the discussion. I'm going to begin by introducing the panelists that we have present. And when I say your name, if you could join us, just to make sure that we do in fact have everybody present that we think we're expected. We'll ask you to take your seats over there as your name is called. We have Mohammed Ashil from the World Health Organization. We have Sahitya Bhaskran from Aravind Eye Care Systems. We have Chungsim Anna Tan from Singapore National Eye Center. And then we have Tashi Tobgai from the World Health Organization. So we're batting 100%. Our effective speaker coverage rate is 100% here in this first group. And then for the introductions of those joining us on Zoom, I will turn to Professor Liang from Zhongshan, who should be online to make those introductions.
Yes, I'm here. Thank you, Tulsi. Thank you, Nathan, Mingguang, and all friends in New Delhi. Unfortunately, due to the visa issue, some of us could not join in person, including myself and Professor Hao Tianling, who sent his regrets for missing this event due to unexpected commitments. I will chairing this section on his behalf, and it's really my great honor. And I did enjoy the lectures we just heard. So now let me introduce our online panelist, Professor Yang Xiao from Zhongshan Ophthalmic Center, Professor Zhu Zhuoting from the Center for Eye Research Australia. Okay. If you may recall that in 2021, WHO member states endorsed a global target of 40% increase in EREC by 2030. This led to the WHO SPACS 2030 initiative. Given the Asia-Pacific's high prevalence of refractive errors, Zhongshan Ophthalmic Center and Arvin Eye Care System saw APAO as the perfect platform to convene this interactive section, SPACS Asia, to bring together experts to discuss coordinated solutions. So to meet this global target, there are a lot of challenges, and the most pressing question we must address is how can we overcome barriers to access refractive error correction services in low-income settings. At AIOS, we share the responsibility to improve eye care access in low-income settings, and our approach is to utilize the power of AI and new technologies, as Professor Lin Haotian just introduced. For example, we developed a mobile app to detect the vision impairment in young children at home, and 5G intelligent ophthalmic vehicle to provide comprehensive eye examinations to remote populations. A large language model called ChatZOC to help provide consultation for patients and training to healthcare workers and students. So that's what we do at ZOC, and I'm eager to hear about the approaches in other countries and by WHO. And Professor Yang Xiao, could you please share your experience?
Yeah, thank you. Because my video is not available, so I just open my my audio. Sorry for that. So for this question, I think the public education competitive.
I'm not sure if we lost her voice.
Sure.
Dr. Yang Xiao, we're not hearing you right now. Maybe it seems and I think you're on mute, Professor Liang.
Yes, maybe Zhou Ting, could you share your experience in Australia?
Thanks, Professor Liang. And I'm really honored to be here and the same issues because of the visa issue and couldn't be on site. I'm really sorry to miss this great conference. And actually, Australia has a Medicare subsidized system that can provide the refractive error or the spectacles coverage very efficiently. And I think the government initiative is very important in this area. And I wanted to mention that the government initiative, especially in the low income settings, is very important. As far as I know that there is an initiative in Australia called the Visiting Optometrist Scheme, which is an Australian government initiative designed to improve the eye health in regional, rural area and even the Aboriginal communities by supporting the optometrists to deliver the outreach services. And I knew one of the optometrists that she has been done these outreach services for a very long time. And the government supported the expenditures, including the travel, accommodations, and low-cost equipment for them to do the outreach services to provide the effective refractive error correction in the remote and rural areas. And so I think the government investment and initiative is very important in the remote and rural areas.
Fantastic. Thank you very much for that excellent question, Professor Liang, and for the good responses that we received. We've got about 15 minutes left for this panel discussion, so I think we'll move on. We have 4 remaining questions. I'm going to address this one first to all of our panelists, and then we can make sure everyone has a chance to respond. What are the benefits and challenges of integrating refractive error correction into the primary healthcare system? I mean, that's kind of the ultimate in some ways. If anytime somebody comes in for primary care, there's the opportunity to access glasses. I'd be interested to hear, let's say in Bhutan, maybe we can start. How would you, is that something that's practical? Is that a realistic goal for us to achieve in your country?
Yes, thank you very much. I think this is a very important question. You asked specifically for Bhutan. Although I work at WHO Southeast Asia region, which we support 11 member states in the region. But particularly on Bhutan, I think it's very important to integrate at the primary healthcare system. And in Bhutan, the government provides free healthcare system to all the population, and ophthalmologists are very limited. And most of the services at the primary healthcare center are provided by the allied healthcare services, and they screen the vision, and then if there's any problems, then they do referral systems to the district hospitals where they get the specs and other approaches. And also from the national and the regional referral hospitals, the ophthalmologists and the team do a lot of eye camps where they provide the ready-made spectacles and also the other eye care services. So I'll pause out here. Thank you.
Fantastic. Dr. Sahitya, I'd love to hear your thoughts on this. Obviously in India there's been phenomenal success in creating an independent, largely private body of eye care service. And I know the Indian government has interest in seeing eye care and hearing services and other things delivered at the primary government centers. What's the progress been so far, and what do you see as being the challenges to deliver on that goal?
Thank you, sir. So in India, yes, we have a very robust outreach system for eye care services, both by the government and also the private partners. However, when it comes to children and school screening, yes, both the government and the private partners have a very good outreach system covering most of children in school screenings. However, integration of eye care services into primary health centers, though the system exists, we do not have enough optometrists who are able to provide eye care services at a PHC level. Also, in remote areas, refraction services and prescription of eyeglasses are still not a reality when it comes to India. And even if they can get refraction services done there and a prescription is raised, patients still have to walk into a secondary or a tertiary care to get an eyeglass. So once, like Mr. Tulsirat said, if you cannot get your eyeglasses at the point where you're getting prescribed, then the uptake is not there and the loop is not complete. And we also have tried to integrate vision centers through school screening. So we are trying to get children to come into vision centers and get their glasses or refraction done there. But as much as you do an outreach camp on site and deliver glasses at the school site, the uptake is about 89%, whereas when you expect children to come into a primary care facility like a vision center, which is supported by teleophthalmology, there is someone from the tertiary care remotely accessing and giving prescriptions, we still find that the uptake is only around 40 to 45%, which is a major challenge, though you have systems in place.
That makes good sense. Thanks very much for that answer. I want to make sure that we try to get through all of the questions that have been laid out for us by the organizers. So this next question is how we can align national policies and programs with global targets for refractive error coverage. And I'm thinking, I want to make sure we get Anna involved here. You know, Singapore, obviously you guys are doing a fantastic job of getting glasses on kids, 90% of wearing them. I wonder if I could slightly bend the question a little bit. The government has a policy of getting kids outdoors a couple of hours a day to prevent myopia. And I think there's some challenges in getting parents and schools to do that. What's your thinking about that? In terms of myopia prevention, particularly through these kind of school-based solutions, is that something that is realistic in Singapore? What challenges are there, and what can be done to start in schools on the prevention side of things? I know it's a little off topic, but I want to make sure we get our Singapore representative involved in the discussion here.
Yeah, I think obviously, you know, it is a much bigger task to be done, and we've been advocating in the ophthalmology society for this change to happen in schools in terms of, you know, playing outside and everything. And obviously, there's a lot of resistance individually in the Ministry of Education. I think they are not very keen on it to implement it, and neither are they in the school level. And the parent level, and then on the teacher level. So I think, you know, you learn from some of our colleagues in China when it came from the government level and it was mandated from the top. And I think that was something that really changed the practices in schools. So perhaps in senses where things are not so attractive, you know, mandating it from government policies from the top. But I think the other thing I wanted to bring up, that actually in Singapore we do face to a certain extent, but because we have a lot of safety nets, it doesn't happen so much, is including spectacles as an assistive device. And I think, you know, right now, many countries have funds and have funds for assistive devices. However, because the spectacles aren't considered an assistive device, you cannot access financial funding for spectacles. So I think one of the things we can advocate for, and also within the primary eye health system, because that is where a lot of these funds are dispersed, which this assistive device funds are dispersed, is to really look at advocating for spectacles to be included as an assistive device. And I think that's an important thing.
Real important. It's ironic in some ways that some of the healthcare services that are most salient to patients, that they're most aware of needing, things that help us to see, help us to hear, help us to chew our food, these are the things that get left on the cutting room floor by healthcare services. And I do think that's something that should change. Mohammed, I wonder if we could ask you to address the question the way it was supposed to be asked, which is about how national policies can help to achieve these global targets for EREC. Feel free to speak both wearing your WHO hat and for your home country as well. I think they're both interesting perspectives.
Yeah, thank you very much for the question. So specifically when coming to India, as you know, India is not just, you cannot take it as a homogeneous country. It's 1.4 billion population with very varying systems of healthcare delivery. If you can say that there's a three-tier system across India, but it's not very homogeneous. And what works in one part of the country does not work in the other part of the country. And if you see at the system, starting from the primary care system to tertiary care system, it's grossly, there are a lot of differences between the states and even within the states. So, and while there are multiple models which are available in the private sector, like Arvind Eye Care system, the LV Prasad, many other things, many other systems which are really working in the field. So and in WHO, wearing the WHO hat, what we're trying to do is now is to understand what is the systems within various parts of India. So WHO has actually revised the tool and kind of adapted the tool that on the eye care system assessment tool, that is EXA tool, to a new tool called RESET, that is Refractive Error Situational Assessment tool. Based on that, what we are trying to do is to understand what is the situation of healthcare delivery system and the policies within the country with regard to eye care and refractive error coverage. And what we and what we are trying to elicit through this is that where our system stands, consider system maturity for eye care delivery, especially focusing on refractive care services. So once we have that, and recently in September 2024, WHO, along with the Minister of Health and Family Welfare, conducted a review of the states and understanding where they stand now. And in that meeting, as you rightly pointed out earlier also, that we have done a good job with regard to the cataract surgical coverage, and also with regard to recently we have eliminated trachoma as a public health issue. So in that case, the focus of the government is currently more towards increasing the refractive care services. And government has launched a kind of mission activity that focus on the policy change with regard to improving the access to refractive care services. So in India, it's a best situation for actually ramping up and accelerating the refractive error coverage, because there is a real political buying in and there is a policy change towards this direction. And that's why we are currently doing a situational assessment. WHO is doing a situational assessment with the help of our collaborating centers, including Tulsi sir's advice. And we will be, what we're trying to do is to come out with a state-specific action plan. Like we have started with Assam, and many other states are all on board, so that we can actually come out with a state-specific action plan, and with very specific target of improving the effective refractive coverage. So if you ask me whether how the policy change is the very beginning of what comes in, and the role of WHO and all of our partners is to actually take the advantage of that policy change, and take the advantage of that policy buying in, and make sure that we are effectively delivering what we are supposed to deliver.
Fantastic. We've got 2 or 3 minutes left in this first session, and I want to make sure that we cover a couple of very scintillating questions. Tashi, I wanted to ask you, we think of Asia generally as having high population density, pretty good transportation infrastructure, but obviously there are other countries like your home country where it can be challenging. What do you think the role is of telerefraction, delivering refraction through distance services? Do you see a role? Speaking again, both for your home country and also from WHO perspective.
Thank you very much. Very important question. First of all, just to highlight a little bit on the previous one, I thought that was very important for us to know as well. The global targets are set, and most of people think it's a WHO target, but it's a target agreed by the member states, by all the countries, and then therefore we need to promote that target going to the countries, and then we WHO promote, support the countries to develop the strategies into policies, and then the implementation approaches. And for example, like the STRIP, so now like governments, most of the governments in the region, we are trying to develop the priority establish, where we can include the spectacles as one of the list. And then once it's become a priority list, then we can promote saying like, this is in your list, priority list, therefore you have to deliver. Maybe the cost is too much, maybe you have to reduce the taxes, maybe the delivery systems are not there, so you have to improve through various mechanisms, as Tulsi sir has rightly pointed out, like through the mobile camps and other things. And thereby, I think this is like how we improve the delivery and achieve the final, both the national target and going back to the global target. So this is how I think we can work together. And coming to the telehealth, I think this is the very important topic, especially like within the region. There are countries is so diverse, like for example in the Himalayas, one house is located up in the mountains where it takes a full day walk to go to the town center to buy a pair of glasses. Forget about the getting the ophthalmologist services. So this telehealth becomes very important. For example, in Bhutan, we have incorporated the telehealth services, where the public primary healthcare centers, where it is manned by allied health services, they take care most of the primary healthcare needs, including the minor injuries, trauma, including the refractive services, checking the vision, all those things. And then they consult with the ophthalmologists at the national referral hospitals, and then like delivery services are done. And when I visited the Arvind Hall Hospital, their vision centers, it's quite amazing how they use the vision centers as part of the telehealth component, and where the vision centers vision center workers, how they consult the ophthalmologists at the center in both like providing this pair of prescription and also the other health care services. So this telehealth can be very, very effective, and now with the modern technology and mHealth and other things, this has become much more easier accessibility, and I think the penetration of the mobile phones, like for example, even in Bhutan, it's like everyone has a mobile phone and everyone can have access to the internet services. So now it has become more important. We can definitely leverage on these services.
Fantastic. Well, we left one question on the table there that hasn't been answered, but that's fine. We've come to the end of our time. I'd like to thank our four panelists for some very scintillating answers. So you're welcome to go back to your seats. And my colleague, Mr. Tulsiraj, is going to go ahead and introduce our next set of panelists for the final panel session of the day. You'll introduce the ones that are here, and then I guess the online ones will be introduced again by Professor Liang.
So to start with, Nathan, you're going to change your chair.
Sounds good.
Dr. Ming from Hong Kong Polytechnic University. Ming. Divya from Aravind. Dr. Julie Yap from Singapore National Eye Center. Let me request Professor Liang to introduce the remote online panelists.
Okay, thank you. Thank you, Tulsi. So now let me introduce our online panelist, Dr. Eric Domingo from WHO Regional Office for the Western Pacific, and Professor Zhiwen Zheng, Professor Xiaohu Ding, and Professor Wei Wang from Zhongshan Ophthalmic Center. Now for our second discussion, we will tackle a crucial challenge: how to improve both the uptake and quality of refractive error correction services. Now let's begin by identifying the key barriers. What are the primary obstacles we need to address in different areas? We have been working on Iraq surveys, and based on our experience over the past few years, we have found that the primary barriers vary by age, group, and region. In areas with moderate and high socioeconomic conditions, awareness may play a bigger role. For children and adolescents, our epidemiological surveys show that the Iraq is relatively higher than that in adult. About over 90% in most parts of China, including rural areas. But the lowest rate is around 85% in primary school, but it increases as academic demands and IUs grow, reaching up to almost 95% in high school. So this shows that the awareness of the parents and students is really important. For adults, the Iraq is relatively lower. In Guangzhou, for adults over 50, the rate of distance or vision correction, it is about 48%, and for near vision correction, it's only about 16 to 18%. So because many adults think that as long as their vision doesn't seriously affect their daily life, they don't want glasses. So, but in remote area, several factors work together, such as the access and availability, cost, awareness and education, cultural factors, and healthcare system. So that's my opinion. Professor Ming Guang, could we have your thoughts on this? We will appreciate your expertise. Thank you.
Yes, thank you so much, Professor Liang. I think before we talk about the uptake, we got to try to understand this is do our target people really need the glasses, for example, the near vision glasses. It all depends on their occupation, the profession, and so on. So and also the awareness is important. The cost is next important in China, because now I think a lot of people can afford it. And also waiting is a problem because if you got to wait for the spectacle to come, it's challenging. But then in China, the good thing is the Taobao and all these online shopping is just so mature. So it's just ordering ready to make, or even with prescription spectacle in Taobao is extremely easy. And it's very low cost. It's unbelievably cheap. It's just 100 RMB, which is like $20 only. So a lot of problems, I think, is because the people, they may not aware of it, or that they may not see they really need it. Thank you.
One point I would just make in terms of awareness for young kids, in China in particular, but in many other countries, there is not just a lack of awareness on the part of parents, but there may be incorrect beliefs that wear of glasses will harm the eyes. And I think we do see that still particularly in rural settings in China, but we see it in Africa, we see it in other settings. With respect to the need for glasses, it's interesting. We've got real strong evidence that presbyopic glasses have big impacts on things like productivity, the ability of an agricultural worker to recognize seeds and someone to make proper change in a shop. People may not be aware of the need. So sometimes someone just saying, I don't need them, maybe we need to go a little bit further and suggest what some of the value and benefits, practical benefits may be. We do find in a lot of our studies like Prosper, once glasses, 0% wear when we started, but once people begin wearing the glasses at work, their compliance goes way up because they do discover the real benefits in terms of productivity. So it's different aspects of awareness, trying to correct incorrect ideas about how glasses are going to be harmful, and trying to give people the opportunity to wear in workplace settings and see what the real benefits are.
Good. Thank you. We have a few more questions to go through, and request the panelists to kind of restrict the responses to a minute or so. We got different perspectives about what the barriers are to uptake. Now switching to the next question, which again kind of relates to the demand. How can we ensure the quality of refractive error correction services, particularly in low resource settings? I think there are two parts to this question. One is about the correct prescription, and the other one is the correct dispensing of glasses. So maybe I'll start with Dr. Julie Yap.
Yeah, so I think, proper training for people, really. I think it's not very difficult to train people to test or refract, actually. We've got so many communities that, like, for example, we've got these communities in Southeast Asia where they want to be trained, and it's quite easy to do visual acuity. And there's things like peak vision that's easy to use. You can use your hand phone. There are now portable auto-refractors as well. So, there's so many methods these days that can help. And then also it helps to collect data that can then be sent over, and someone can be off-site and making sure that they're doing it correctly as well. And then I think now they're also 3D printing of the glasses, and there are a lot of different organizations like Essilor, for example, or Fred Hollows, that have been so active in these areas. And they're going in and they're helping out, and they've got programs such as the Vision Ambassador as well that do active training in different countries like India, Africa, Southeast Asia. So I think these are all different methods in which we can improve the uptake as well as the quality of provision.
I think training is crucial. I would add to that regulation. So a lot of countries like Mongolia, for example, folks that are refractionists are regulated in the same way that barbers and beauticians are. It's not seen as being a medical practice. And so I think that's real important as well, to have quality control. Someone not only at the time of training, but someone looking down the line and regulating the quality of service as well.
Yeah, I think even in Singapore, you have people who are just auto-refracting and opticians who are just giving out glasses. So in some cases, you find patients coming in and they have got the wrong prescription, for example. So, I think it'd be good if there can be a bit more regulation, and I think that's something that we could work on generally.
Good. I just want to also recognize those joining remotely. Maybe if Dr. Wei Wang wants to supplement this aspect, if you're online. Or Dr. Eric Domingo. Wei Wang is there. Yes, Wei Wang. Yeah.
Thank you. This is thanks for the question. I think we agree that the common barriers like economic burden, limited accessibility, and low awareness are important. But I'd like to highlight two additional points that actually are often underestimated in practice. In low resource settings, one of the most practical and scalable solutions to implement competence-based training for middle level persons, such as vision technicians or community health workers. Instead relying on fully trained optometrists, we can equip non-specialists with simplified, validated refraction protocols that focus on essential skills. These skill packages can be used in short modular training programs and include decision trees. Evidence from several countries show that with adequate supervision, such cadres can achieve outcomes comparable to more specialized providers. In addition, I think one particularly promising issue is the telemedicine and the mobile tools, such as use of self-testing virtual mobile apps, especially in areas with limited access to personnel. A good example is the WHO app developed by WHO and Ming's team. It lets people check their distance vision using just a smartphone. It's free, works in multiple languages, and can be used by teachers, parents, or even individuals themselves. Earlier pilots can be showed is a cost-effective ways to catch refractors errors easily, especially among school-age kids. And as smartphones become more and more common, tools like this could really help turn passive populations into active seekers of eye care. So this is my opinion.
Thank you. Eric, I see your hand up. You want to supplement?
Yes, thank you. I just want to make two comments. Number one, on the quality. For the WHO Western Pacific, what we try to do is help countries develop standards, guidelines and easy protocols to follow. And then, of course, we need to identify quality indicators to make sure that, the services that being done, when we have to monitor and check and to make sure that we are up to standard. And one other comment I just wanted to add was about access to care. We know, like Astashi said, like for his country, it's very similar in the Pacific Islands. These are very small countries, very few professionals, and very difficult to get commodities there. But we have to also realize that even in the bigger countries, for example, in East Asia, we do have still people who are unreached, like women are being corrected less than men by about 10%. We have indigenous populations that are not being served. You have disabled people, and we have underserved populations that we still have to work on. So sometimes what we're missing some people who are there, and we might be able to reach them more effectively. Thank you.
Thank you. I'm going to switch the order of questions, and let me pose a question to Divya about how do we raise public awareness to increase the EREC uptake?
I think while awareness is important, I think that is something that can only be achieved through better access. By making spectacles more easily accessible, I think then we can, that should go hand in hand with awareness, because we've seen a lot of public education efforts that focus so much on awareness, and people are probably hopeful and are looking forward to or even curious about it. But if access doesn't follow behind quickly, then I think I'm a big believer in access. So I think even without public education, if we just make refractive services and spectacles, affordable spectacles available within reach of the people, I think education will be taken care of.
Okay. So you're posing the chicken or egg question. Yeah, so they're so interconnected, yeah. So let me ask Nathan.
I actually wanted to say something about
yeah,
awareness.
please,
Yeah. I just think, there's so many young people who are, I'm not talking about so much about presbyopia, but more about my myopia in young children. They're all glued to their phones, and they're quite influenced by big personalities and media personalities. And I think that there have been some small push advertising, like programs in Singapore where they've used influencers.
Yes.
I hate that word, but there are some influencers who are actually using their influence to do some good. Or putting glasses on cartoons, for example, just making children be aware that it's okay to wear glasses, things like that.
Yeah. Thank you, yeah. Usually when you have a target-driven program, monitoring becomes critical. And I think if you're not able to monitor, things don't really improve. In the EREC program, that seems to be a weakness in the sense we are now kind of dependent upon population-based surveys to monitor, which we know that happens once in 5 years, if at all. So I want to ask Nathan and Ming, are there other ways that one can monitor, or we have to depend only on this population-based surveys?
Yeah, it's a great question. I'm a real believer in targets of opportunity. So I like the idea for kids of school-based approaches. I think monitoring in schools is pretty easy to do. Comparatively speaking, it's one more visit effectively to come back and see if kids are wearing and see how see whether the new glasses power is needed. And then for adults, I think we really should focus on workplaces. Some of those are easy, factories, plantations, things like that. And I'm not saying that's the full answer, but I think given the reality, maybe, every 5 years we do one really big study, but then if we're finding that people in workplaces and at schools are generally pretty well cared for, and let's say maybe residential homes for the elderly, another relatively easy target, I think that gives us something we can work with so that we're getting regular data from low-hanging fruit, easy places. These are also the easiest places to deliver services, and so they're highly relevant. And then, every 5 years or so, we splash on a big population-based study. That would be my thought.
And Tosi, I really like your idea. When you present the idea, one particular day, you use this opportunity screening or opportunity surveillance. In one day, among these walking patients, how many of them? I just try to understand the data. I mean, based on this, I took a lot of video on this. But then my idea is that, given the fact that WHOI has been adopted and promoted as a tool to have an easily assessed visual acuity measurement. So we actually work with other colleagues in China. We just encourage everybody using WHO eyes as an opportunity to measure your grandfather, grandmother, your family member, or just your peers, and then just measure the visual acuity. So as a way that if one day everybody doing this, then we have a very quite a good data to understand IEC. Thank you.
Yeah. Good. I think we're getting a very strong argument that you measure process which happens on a daily basis, school screening or individual screening or workplace screening or even the hospital-based service delivery. And I think if improvements happen there, eventually we're going to see that impact in the community as well. Yeah, thank you. Let me ask one of the remote participant, maybe Dr. Zheng, on innovative technologies. Today I think we are in a huge area where new technologies are popping up every day in multiple areas, including on refractive errors. So how can technologies help in improving either uptake or quality?
Okay, I'm Dr. Zheng from China. I'm sorry to missing the on-site meeting because the visa application problem. I think it is very impressive for me for the iron eye care system. They have a very good refraction error recovery system. This system, I think, in China is also a very good, but it's different in different region. In the big city, the refraction coverage is no problem, but in the countryside or some poor place, the refraction coverage is still not very good. Irving said that they have 80% recovery. I think as in China, probably is not. Some in countryside or poor area, the recovery probably is less than 50%. So, but in the city, the big city, the recovery is, I think, is higher than 90% or even 95%. So it's a big diversity. So I think it's very important to have the enhanced recovery of refraction in different region. So, personally, I think if we have a very good technical system, and then we can screen or can make a very good diagnosis for refraction error first, and then we can give them free or something for the poor area. In the city, probably is for purchase, not free.
Thank you, thank you.
Yeah, I think in China, the refraction error in the elderly probably is common, but for the kid, for the school student, for the myopia control is most important. The regular or the simple glass refraction is not good. Needed more device or intervention for myopia control.
Thank you, thank you. I'd like to give a chance to Dr. Ding to supplement on any of the issues that I've been talking about. Now, Dr. Julie also talked about using technology for increasing uptake or awareness. So, Dr. Ding, yep.
Thank you. I'm Xiaohu Ding from Zhongshan Ophthalmology Center. I think Professor Ming has said awareness is the most important barrier to the uptake of refractive error correction service. So, innovative approach is we can using short videos, given the widespread popularity of short video across all age group in China. We can produce some short videos to enhance the dissemination of scientific knowledge about refractive error correction. At the same time, we can invite some well-known ophthalmologists to participate in these short videos. By using the star effect, we can significantly increase the credibility and attract a broader audience. That's my opinion about this issue. Thank you.
Okay, thank you. So we have another 2-3 minutes, and I'd like to open it to the panelists to make some open comments. Nathan.
Just to respond to the question about new technology and its role in improving refractive coverage, we have seen that school-based models of screening have a lot of strengths. It's we can get a lot of kids in schools, they're highly concentrated, it's cost-effective. The problem is often when we do referrals of the kids that screen positive, even to relatively nearby facilities, the coverage is not always great. Not a lot of people show up.
The compliance is not.
Yeah, compliance with referral is not so great. Yeah. So one of the things that we've been examining at Orbis, particularly in settings like Mongolia, where the distance between the refractionist and the kid is hundreds of kilometers, we've been looking at self-refraction. And I would say overall the evidence is pretty encouraging. You know, generally speaking, between 85 and 90% of kids will get good vision results. There are going to be kids who have a lot of astigmatism and other problems. But I think that can be used in a couple of ways. First of all, in areas where it's just not practical to get refractionists out there, hundreds of kilometers away, and kids aren't going to step on an airplane, we can use self-refraction by itself. In other settings where we have some refractionists, but there's too much work for them, there's the potential to do an initial self-refraction. 80% of kids get good vision. The 20% that don't can then be seen by an optometrist. They're going to have astigmatism and higher myopia and other problems that require refractionists. So self-refraction, a lot of technologies, they've been around there for 10, 15 years. I think that is a technology that deserves further attention in terms of getting that refractive error coverage level up.
Excellent, yeah. Any other closing comments from those who are here? Divya, Julie, Ming?
One thing, a couple of points. One is related to quality. I think one is the quality of the spectacles, but I think one of the things that also comes up in the effectiveness data is old spectacles when the prescriptions have changed. So what is our mechanism for follow-up? So even in schools, whether we have a regular way to go back to the children and screen them. And I think especially with workplaces, like the tea garden managers are going to be, I think, more than willing to pay for the glasses because they're going to get so much more back. And also convincing them about, say, maybe a checkup every 2 years, you're going to refract them and replace the glasses. I think this mechanism also needs to be there in addition to the other surveillance mechanisms we have. The second is just want to also add to the access part of spectacles, ensuring that it is available as close to the refraction estimation service, that when you refract someone, almost immediately if you're able to give them access to spectacles, then the uptake is much higher. And you don't have to make it free. You don't have to give second-hand glasses. We've seen more than enough that people are willing to pay for affordable, of course we make them affordable, but still at a profit, high quality glasses, new glasses. So I think just fixing that supply chain, and with these huge numbers that we're seeing for refractive error, I think we will definitely have the scale to do this. And I think that's what we should leverage and make sure that we're making this possible. Today with technology, we're able to see that at our vision centers, we only have sample frames. Just using a steady sample of frames, we're able to have a good inventory back at the hospital, and we're able to fulfill these just within a couple of days. And because patients are within a 5-kilometer radius, they're willing to come back within a couple of days and pick them up. So I think this way we're able to see more than 90% uptake. Thank you.
I just had a point to make about awareness again. With presbyopia especially, they don't even need to come in really to get tested. If once you teach them, you educate them, they can go to the shop themselves and then test the glasses, make sure they have a reading chart, which is easily available online, and they can just do that themselves. As long as they know that they probably have to do that every 2 or 3 years, then it just reduces the chance of them having to come back, and also the compliance.
I think that's a real important point. There aren't shops in a lot of the places we're talking about, but I think you're 100% right. The distribution pathways for presbyopic spectacles can be different. We've shown you can readily train a village health worker, someone with no medical experience or eye experience, to take a patient through the process of selecting useful glasses that are going to change their productivity. Yeah. So I think that's a real important point. We should be thinking about presbyopia. In some ways, it's a different thing. It shouldn't just be linked in. It's going to be completely different and often much easier supply chains.
And I personally think beyond this awareness, I think making spectacle really easy to access is quite important. Like for example, in the supermarket, 7-Eleven, just put this ready-mix spectacle over there, and then people can experience it. Even my mom, I always try to bring my mom to hospital to have a best spectacle, but she always say next week. So what I try to do is just bring him, just give her a ready-mix spectacle, and then she can watch the TikTok. Yeah. And then I ask my mom, test your visual acuity with WHO eyes. And then, oh, it's not good enough. And then you should visit the hospital, have a better glasses.
Thank you. I think this was a rich panel, both panels 1 and 2. We certainly haven't solved the problem of refractive errors, but we got a lot of good insights. So I want to thank the panelists and the audience for their participation. Thank you very much.
And thanks very much to our online co-chair as well, to Professor Liang. And we're sorry that the Director Lin couldn't join us today, but thanks very much for all our online panelists from Zhongshan and from elsewhere.
Thank you so much.
Recording stopped.